everyone, it's Julie and my partner is Margot, and today we're gonna discuss about the drug called Ciclesonide. So I am called Ciclesonide as well as my generic name. I have three brand names called Alvesco, Omnaris, and Zetona. My chemical name is 6-cyclohexyl 11-hydroxy 13-dimethyl 16-oxo 5-7-dioxy pentacycloic cosa 14 17-diene-8-il 2-oxoethyl and 2-methylpropanoate. Upon drug classifications, I am in anti-asthmatics and therapeutic, and in terms of pharmacologic, I am a corticosteroids. And my pregnancy category is I am under pregnancy category C. In my mechanism of action, I am converted to the pharmacologically active metabolite. This is butyryl cyclesonide, which has a high affinity for the glucocorticoid receptor, and I exhibit an anti-inflammatory activity. So the glucocorticoid drug in me is converted to an active ingredient called Ciclesonide, and it has an immunosuppressive properties, anti-inflammatory activity, and anti-inflammatory effects.
Now for the pharmacokinetics, I have negligible oral bioavailability, thus I am absorbed locally. Now for the distribution, I have a volume of 2.9 liters per kilograms. 99% of me is binded to protein, and I am metabolized at the liver. Also, I am eliminated in feces via biliary excretion, and less than 20% is excreted in urine. For the indications, I am indicated for the treatment of nasal symptoms associated with seasonal and perennial allergic rhinitis. Also, I am indicated for maintenance treatment of asthma as preventive therapy for patients at the age of 12 years old and above. Take note, I am not indicated for acute treatment of bronchospasms. There are two ways you can administer me. First is through inhalation. Now, inhalation is used for asthmatic patients. For patients with asthma, I am to be administered as a metered dose aerosol containing 80 or 160 micrograms per actuation. You can administer me for 160 micrograms as a single or in two divided doses daily as 80 micrograms. And for maintenance, you can reduce the dosage as 80 micrograms daily. Now for patients with severe asthma, you may increase the dosage up to 320 micrograms twice daily. Now second is as nasal spray. This is for adults and children with perennial and seasonal allergic rhinitis. I am administered as spray containing 50 micrograms per actuation. The dosage to be given is 200 micrograms daily. So, I am given as 2 sprays per nostrils once daily.
So, contraindications. I am contraindicated in persons or people that has a hypersensitivity to cyclesonide or any other ingredients in the formulation. Also with patients that has acute asthma or status asthmaticus. I am also cautiously used in geriatric patients. I am also cautiously used in obstetrics, and you have to decrease the dose. And in case in lactating women, there are many corticosteroids that enter the breast milk, so hypercorticism may be seen with increased maternal doses. And in pediatrics, safety and effectiveness in children, cautiously used in children.
Now it's time for my side and adverse effects. For the central nervous system, you might be having headache frequently. Now for the ear, eyes, nose, and throat, there might be a candida infection of mouth and pharynx, nasal congestion, nasopharyngitis, pharyngolaryngeal pain, cataracts, and increase in intraocular pressure. Now for the endocrinologic, there might be adrenal suppression and decreased growth for children. For musculoskeletal, there might be arthralgia, back pain, decreased bone mineral density, and extremity pain. And lastly, for the miscellaneous effects, there might be worsening of infection.
So, my nursing responsibilities. Before, the nurse must monitor a respiratory status and lung sounds. Pulmonary function test may be assessed periodically during and for several months following a transfer from systemic to inhalation corticosteroids. So, you have to assess the patients changing from systemic corticosteroids to inhalation corticosteroids for signs of adrenal insufficiency during initial therapy and periods of stress. If these signs appear, notify healthcare professional immediately. Conditions may be life-threatening. So you have to monitor for withdrawal symptoms. And during withdrawal from an oral corticosteroids, you have to monitor the growth rates in children. You're receiving chronic therapy, you have to monitor patients with a change in vision or with a history of intraocular pressure, glaucoma, or cataracts closely. And we have some lab test considerations containing periodic adrenal function tests may be ordered to assess the degree of hypothalamic pituitary adrenal axis suppression in chronic therapy. And children and patients using higher than recommended doses are at high risk for HPA suppression.
Lastly, for the nursing responsibilities after, teach patient proper management of the symptoms of chronic asthma. Instruct patient to use inhaler at regular intervals as directed. And advise patient to follow instructions supplied. Advise patients using inhalation corticosteroids and bronchodilator to use bronchodilator first and to allow 5 minutes to elapse before administering the corticosteroids unless otherwise directed by healthcare professional. Advise patient that inhalation corticosteroids should not be used to treat an acute asthma attack but should be continued even after inhalations agents are used. Advise patients to rinse mouth with water to decrease the risk of developing local candidiasis. Caution patients to avoid smoking, known allergens, and other respiratory irritants. Advise also the patient to notify healthcare professional if sore throat or mouth occurs or if exposed to anyone with chickenpox or measles. And lastly, instruct patient whose systemic corticosteroids have been recently reduced or withdrawn to carry a warning card indicating the need for supplemental systemic corticosteroids in the event of stress or severe asthma attack unresponsive to bronchodilators. Now that is all, guys. Thank you for listening to me and my partner. I hope you have learned something. Signing off.